Welcome back to the House Committee on Gov.Ops and Military Affairs on Thursday, February 9th. Our second half of the morning session here. We're back with looking at language on the OPR housekeeping draft committee bill language that we were looking at earlier this morning. And so I'd like to invite Deputy Secretary Hibbert to give us testimony on the bill.
Thank you so much. And again, for the record, my name is Lauren Hibbert. I am the Deputy Secretary of State, and I'm here with Lauren Lehman, who is General Counsel for the Office of Professional Regulation. So I'm just going to go right into the sections. Section 1 is modification of Title III, and that is our umbrella statute that controls all of our professions. We like to make changes in that section because it applies to all. What we're doing in this section is really two things. We're streamlining our denial process for applications, and we are setting up the authority for a hearing panel on disciplinary cases. The first thing we're doing, the streamlining our denial process, we deny applications for two core reasons. One, somebody committed unprofessional conduct, past or present or ongoing, in our state or another state. So think about, going back to my testimony earlier this morning, the nurse who diverted narcotics in Texas, we have the decision in Texas and he comes to our state and he's seeking a Vermont license. We would deny his license because of his unprofessional conduct in Texas. That is what we call conduct denial in-house. That's what we call it. And then the other reason why we deny somebody a license is because they don't meet our qualifications, our Vermont qualifications. The changes in this bill clarify that we will send a notice to the applicant, a pre-denial notice to the applicant when it's a conduct denial. That person would then have the ability to appeal that pre-denial notice and have a hearing in front of the board or an administrative law officer. They would have the opportunity to present evidence and say, no, you're wrong. I should be entitled to the license because the conduct happened 20 years ago and it's a felony that's not related to the practice of the profession. And I've rehabilitated myself so much that you should give me the license. And then that board or the administrative law officer would make the determination. The second category of denials, the category of denials on the basis of qualifications, those are people who we've received their transcripts, we've received their exam scores, their national exam scores. We've sometimes received references, we've received their supervised practice. And the universe of questions is smaller and the conversation is usually more involved between our staff and the applicant because we're going back and forth of, okay, that course didn't meet the qualifications, but do you have another course? And so we're going back and forth and back and forth and back and forth. And so what this statutory change does is it allows the board, if it's a board profession, or the office, if it's an advisor profession, to write a final decision of after that discourse to say you're being denied because of qualifications. This will ultimately speed up the process for the applicant because that final decision can then be appealed. It won't be appealed to the board or to the administrative law officer, but it will be appealed to the appellate level, which is in-house. We have an appellate level in-house. And then ultimately that also can be appealed to the Supreme Court. So it's not a final decision, but it's a final decision with respect to appeal rights, legally, with respect to appeal rights. And I should just add that with the conduct pre-denial, there's also two levels of appeal after that hearing in front of the board and the administrative law officer. And the Office of Professional Regulation really supports and desires this change because procedurally it's very complicated. In a conversation about somebody's coursework and then immediately go and then to have the conversation in a hearing and have to almost pretend that you didn't have the conversation last week about the qualifications. It's very procedurally messy. So this is a clearer, crisper process for the applicant and for our office. And I'm happy to answer any questions on this particular section of what is happening in section 1.
So before questions, I just want to say for the committee's knowledge that it's my intention for us to hear the bill. This language has been drafted and worked on, obviously, by the office. So, OPR is presenting this language to us as requests. We'll be hearing from stakeholders. So this is the initial presentation of this draft housekeeping bill language. We'll hear from stakeholders on each of the sections as appropriate before we, go to a vote on the bill. So we're probably going to have this for, a day or two more. But I just wanted the committee to kind of understand that it's my intention to obviously move this bill, but we're not going to be doing it today. I think I didn't do that table setting earlier. I apologize. So on section 1 on this board process, so there's essentially right now one appeals process, whether it's conduct or qualifications. And this would clarify that the qualifications piece, there isn't sort of this messy duplicative piece at the beginning.
That's exactly correct. I couldn't have said it better.
Okay. Does anybody have any questions about section 1?
All right.
Okay.
The second piece of section 1 is the ability of the board or the director to designate a hearing panel for a hearing. And we have disciplinary cases. Sometimes they're very complicated. Sometimes they could be multi-day. Our boards are consisted of professionals who have careers and public members who have obligations. We sometimes can't take a whole board, 9 or 10 people, and say, we need you for 4 days in September. That's a really large ask of volunteers. So if we know what this language does is if we know that we are going to need to have a multi-day hearing, we could designate a hearing panel who would volunteer to do that work on behalf of the board, and they would hear the case, and then the decision would ultimately go back to the board after the hearing panel reviewed the facts and evidence.
Representative Payne.
Thank you. Would the hearing panel that consists of at least one professional member and one public member be in that area of jurisdiction?
Absolutely.
And
yes.
How is that different from the board itself?
So it could be the processes we're envisioning it is, let's say there's a huge case in front of the Board of Nursing. We would go, the Board of Nursing, the director would go in front of the Board of Nursing and say, we have a matter that's scheduled to be in front of the Board of Nursing. It's anticipated to be 5 days. We need professional members from the Board of Nursing to volunteer for a hearing panel. Would you like to designate a hearing panel? And then we would ask the members of that board if there are volunteers who would be available for those 5 days in September. If there's not enough people to do the hearing panel in September, we would then go into our licensing base and we ask everybody when they renew, are you willing to be an ad hoc member? So we can query that list of people who've previously volunteered to be ad hoc members. And we can see if we can find professionals to be our ad hoc member on the hearing panel.
And would they receive training in order to be able to adjudicate this case?
The ad hoc board members?
Yeah.
Yes, they would. They would receive some training from the office. We actually had a case last fall against a sitting board member, and we had to designate an entire ad hoc board. And we provided training to the entire ad hoc board on the process. The goals of the mission of the office is public protection, not to be punitive, and the logistics of the hearing and all of that. And it actually went really smoothly. So that is built into our process. Representative. Okay, and then the last part of Section 2 is the last part adjusting Title 3, and that's synchronous virtual continuing education. That is exactly as what was described. It means that the teachers in one space and the students in another space, and the education and the learning are happening at the same time. What we're doing here is in multiple areas of the law, in our multiple profession-specific statutes and administrative rules, professions say you need to do 30 hours of continuing education. And in many of them, they say 8 of those hours need to be live. And we want to just say, if the statute or administrative rules say 8 hours need to be live, those 8 hours can be synchronous and virtual. But we are not changing all continuing education to be synchronous or virtual or live, if that clarifies. We know that a lot of people receive the majority of their continuing education from recorded videos. But if there's a statutory or administrative rule requirement that requires some portion of the education to be live, it could be supplemented, or the equivalent of the live requirement could be the synchronous and virtual requirement, because that is essentially live. It's just a different format. And this is something that we learned during COVID. We did not have any policy that allowed this. All of our continuing education requirements that had a live component meant that you actually had to go somewhere and sit in a room and receive the education, which is all well and good until COVID happened. And so we issued a policy under the emergency provisions of the governor to allow for synchronous and virtual. We have not seen any decline in competency of our professionals as a result. It certainly is easier for our professionals to get this type of live continuing education over having to drive to a location for training. I do think there's a little element lost of like the conversations you have by the water cooler during the training, and there is that. But I think that continuing education providers are trying to mimic that in a variety of ways. There's sort of chat rooms, and there's, live question and answer. This is, always developing and always improving. And the benefit is so significant for our professionals to be able to take synchronous virtual education that we thought that it had value across all of our professions. So that's why we're requesting it.
So other than the 8 hours of the live training that could be synchronous, could the rest of the training be asynchronous?
Yes. And just to be clear, the 8 hours and the 8 out of 30 was just an example. It widely varies across all of our professions. Mm-hmm. But yes.
So then regarding the bill, there's no need to put in asynchronous details because it's just regarding.
Yeah.
It's just,
yeah.
What our goal is just any place where the statutes or rules under our umbrella refer to live continuing education, we are saying synchronous virtual is equal to live.
Right. So this is when Ledge Council was giving a presentation, this was the thing about it's not appearing in the specific professional requirements. It's in the overarching title that covers all of the continuing ed and the authority of the office, right? And it's saying if there's a live requirement, synchronous virtual is the same as live. Mm-hmm. But it doesn't impact any of the asynchronous.
Correct.
At all. Doesn't touch that.
Absolutely correct. And it's the beauty of the umbrella system, because if we had to go into every statute, this bill would be about 20 pages longer. So it's the beauty of the umbrella feature of OPRs that we can make changes in one place that affect and radiate into all places that we regulate. And we also would have to amend, I think at least 16 different sets of administrative rules. So with just this statutory shift, we can reduce that barrier for our professionals.
I should also say that it's very similar language, pretty much the exact language was adopted last year for our mental health professions. And so it's already included in some of those 26 chapters, and we've just moved that up so it covers everybody.
About this section. All right, let's keep moving.
All right, so this is Lauren Lehman, General Counsel of OPR for the record. So section 3 here is an amendment to modernize the barber and cosmetology statutes. Right now, there's under law an opportunity for vocational correctional facilities to provide instruction in barbering without obtaining a license or any inspections from OPR. And this just expands that to include cosmetology as well. So that's a simple correction there. Any questions? Not hearing any, I'll move on to section 4, which is our osteopathy. So the initial part of this, again, is modernizing. There was, when this was written, the process at OPR was submitting a written form to OPR for an application. This just reflects our current process of electronic application. It also brings into, it makes consistent with the rest of our practices that there'll be a pathway for osteopathic physicians who have left practice for more than 3 years to come back into practice by paying a fee and reinstating their license, often with some continuing education. And then the final component, the practice of osteopathy has changed significantly in the last 20, 30 years to the point where it's very comparable to allopathic MD practice is the traditional model we know. Now there's really no distinction between an osteopathic physician's scope of practice and an allopathic physician's scope of practice. However, the statutes still reflect that older distinction, and they require 40% of the continuing education for osteopathic physicians to be in osteopathic medicine. It's become so synonymous now that osteopathic specific education defers to the allopathic education. So really this is a distinction without a meaning, and folks call us every year saying, where am I going to find osteopathic specific education? So we'd like to eliminate that, keep the same number of continuing education hours required, but just take out that osteopathic specific education requirement. We've talked with the Vermont Medical Society. I don't want to speak on their behalf, but they seemed amenable and they'd heard from a similar thing from their members. The next section, and there was some question about context here, it's the pharmacy section, section 5, and it starts on page 8 on the top. So the initial part here, the context is this amends provisions that were adopted in 2020 after a lot of discussion, so pre-COVID even, that allow pharmacists to engage in some limited clinical practice. That means just prescribing on their own and then dispensing to the patient, sometimes administering the medication to a patient. This is obviously has to be very tightly controlled. The process is what they call a state protocol. And that protocol lists off the specific medications that the pharmacist can prescribe, dispense, and administer on their own without the oversight of a physician. That protocol has to be developed by the Commissioner of Health and signed by them with the advice of OPR's director. So in that current list, there are influenza vaccines, self-administered hormonal contraception, tobacco cessation, EpiPens, and I think a few other things as well. What we've heard is, first of all, that they initially intended and would like to include the Depo-Provera shot in the definition of self-administered hormonal contraception. So that is something that a lot of the population wants, can be safely distributed, prescribed, and dispensed to the population. To allow that in the existing statutory structure, we had to slightly modify the definition of self-administered hormonal contraception because Depo-Provera is administered through injection under the skin, a subcutaneous injection. That subcutaneous route of administration was not previously included in the definition of self-administered hormonal contraception. So what you see here on line 9 on page 8 is including subcutaneous as a route of administration for that hormonal contraception. Then we hop into 2023, which is that state protocol you see. And you can see just, the structure of it right there, that a pharmacist can prescribe, order, and administer in a manner consistent with this state protocol these approved medications that are approved by the Commissioner of Health after consultation with the Director of OPR and the Board of Pharmacy. On the next page, we've added to self-administered hormonal contraceptions, I'm not going to, I do not have a chemistry degree, and I will not pronounce it. I'm just going to say Depo-Provera, because that was what, that's the brand name.
I have a chemistry degree and I can't. I have a degree in biochemistry and I can't pronounce it. So
All right.
it's been a while.
We'll defer to you if we need to. I did want to say that term including is, there's a provision in Title I of the statutes. It's about statutory construction. And the term including is automatically including but not limited to. So anytime you use the word including in the statutes, it's automatically interpreted as including but not limited to. So here we've said including subcutaneous depot shots. It does not, it's not exclusively including those. So down to the next protocol, revision. Right now, the protocol just allows pharmacists to provide influenza vaccines. We all know, especially over the last 3 years, that they provide a lot more vaccines, and that's been really supportive for the public health and for our primary care physicians out there and other hospital providers. What this does is expand the vaccine list to include, for patients 18 and older, all those vaccinations recommended by this advisory committee on immunization practices. It's a committee that's associated with the Centers for Disease Control and Prevention that makes all the recommendations for what vaccines adults should receive and at what time frame and schedule. And so this would allow pharmacists to administer those vaccines to adult patients in accordance with that schedule. That schedule will change. There might be COVID, there may be, God forbid, a new pandemic where we need a new vaccine, and the ACIP schedule might change. That schedule underlying could change without the state having to go back and add to this state protocol or change this protocol. So we're relying on that ACIP review practice and standard. So that concludes section.
Just say one thing. Yes. I just want to say one thing, which is there's a moving piece in pharmacy that I just wanted to give this committee a heads up on, which is that the PrEP Act is expiring in May, when the PrEP Act provisions, which allowed until this change is put into the law, which allow pharmacists to give the COVID vaccination, also allow pharmacy technicians to give the COVID vaccination, and also allow all of those folks to give the COVID test. We anticipated that the PrEP Act would not be extended at a point, but now we know a date certain. And there may be an amendment that we come before this committee on related to specifically pharmacy technicians would be the space that I think it would need to be amended if we can get some consensus around it. So that is the work of the next couple of days for Lauren and I myself. And if we can come to some resolution about how to resolve that issue, then we would ask this committee for an amendment.
And so some context about the PrEP Act is the federal government preempted state licensure laws that prohibited farm techs and other folks from administering vaccines or tests during the national state of emergency. President Biden last week announced that they're ending the national state of emergency and the public health emergency on May 11th. And with that goes the authorization for farm techs to pharmacy technicians to provide these, administer these shots. So that would be the context in which we needed to address this.
So as a person out in the public, it has seemed to be a great matter of convenience and the ability for people to get vaccinated at their pharmacy. Are there any scope of practice? You know, I think about there, sometimes there's a real tension when we expand the scope of practice. Are there, you know, are we gonna, are advocates of other medical professions, are we gonna hear from them?
Yeah.
Pushback, do you think, on this, or is it pretty?
I don't know about if you'll hear pushback. That's part of the work that I want to explore. I think you'll hear support from the pharmacists and some words of caution from the physicians, but I don't want to speak for the physicians. So I don't know whether they'll oppose it. be kind of neutral on it or be positive about it. I do know that, I think there's a large understanding of the important role that pharmacists play in the community public health network, that they're an important piece of the healthcare fabric and recognition of that. So I just want to explore it and really understand where everyone is on it. But I do know that the world has gotten accustomed to being able to get their shots at the pharmacy. And that has taken some pressure off of primary providers and the healthcare industries. So that's the work of the next couple of days.
So I would say, and then I'll go to you, Representative Higley. We'll ask the organizations representing physicians and the commissioner to come and testify, and this will probably get a drive-by at least in the healthcare committee before it moves on. So we won't be the only ones weighing in on this because it does have cross-jurisdictional implications. I just wanted to flag for everybody.
Yeah, no, it's interesting you say that because I know my primary care physician doesn't have the flu shots and recommends to go to your pharmacist and generally it requires a lot of times a appointment, but still that's what my primary care is recommending now.
That's become sort of the standard model, so.
I'm feeling that's what we will hear. Representative Morgan.
Yes, just a comment on that is, it's a great concept. It's great. I think it does help. It facilitates moving that process along. But I have heard from one person that in that field that it also, though, has just lengthened there was one point during the flurry of COVID shots that they were working like buku hours, like tons of hours that were.
Yeah.
So, I mean, I get it. We got to do it. We got to figure out how to get it done. But it's good, but it was bad for them that.
Right. So, I mean, I think just because they can doesn't mean they have to. And I think that it's important that pharmacies manage the workload and mitigate the stress on the employees. But it definitely, pharmacists and pharmacy technicians were part of the frontline response to COVID. And sometimes that's forgotten, and it's undeniable from my seat as the previous director that is true. The workload was immense for them, as it was in almost every health.
No, I remember them talking about it, that it was exhausting for this person because their day was extended
And I think the consequence for this PrEP Act authorization and what might be brought to you, what we're going to work on, is that if it's not extended, but we still have the authorization for pharmacists to administer these vaccines.
Yep.
The pharm techs cannot administer the vaccines. It just puts more of the burden on the pharmacist and they might not be able to absorb that capacity. So that's the concern about taking the pharm techs out of that.
Sure. Great concept. Like I said, it was just a comment that.
Yeah. And anytime that we talk about pharmacy, I like to just tell people about the very, very important role that pharmacists do. I think a lot of us don't have a full understanding, but, and including myself, and you'll have the Association of Pharmacists in, and they'll give you a better understanding. But, they do a drug utilization review on every prescription, new prescription, to make sure that the prescription is the appropriate dose for the patient, that they frequently find prescription errors of providers, that the prescription does not counteract with something else that the patient is taking. A lot of patients get prescriptions from multiple providers and the other providers may not know what the patient is taking. So they really have a very essential role to make sure that the prescription you're prescribed is the right dose, the right time, the right administration, and will not hurt you with respect to your other prescriptions. And then they provide prescription counseling in a very sometimes more in-depth manner than the prescriber. So we want to make sure that they still have time for that really important work as they're doing their day.
And more.
Yeah, just a commentary on that. I've had that happen twice in my lifetime where they've said to you, you sure? That right? And went back and conferred with the physician. They're like, ooh, wrong dose or wrong, actually one time wrong. They felt wrong medication or more appropriate would be this. So to their credit, yeah.
But they play a really key part in making sure that we all are safe.
And like you said, the counseling component, they're very knowledgeable about, like, they have the street smarts on the medications they're giving out, which is huge.
And they're usually, watching the new medications and the side effects and how they'll work with other medications. And yeah, they're very knowledgeable, healthcare providers.
Right, so the next, section 7 is on page 9, line 10. This removes the 1-year requirement for holding an unrestricted license for at least 1 year for pharmacy managers. We have no evidence that that is necessary to protect the public. To a previous question, if somebody's license was warned yesterday and today it's not, it's because the board determined that whatever warning or reprimand they needed to fulfill, they did fulfill that. And so they're now unrestricted, should be allowed to practice. And also pharmacy managers can be really hard to find. And so by putting this requirement in, it creates a bottleneck in the system that hasn't proven to be necessary this time. So.
And I think I asked this question earlier of Ledge Council, and this could start the day or the day after someone's restriction is lifted from their license.
I mean, if that is the case, the determination has been that the restriction has been served, whatever rehabilitation that needed to take place to address that concern has occurred, and so the restriction's been lifted, coursework or testing or whatever.
Does the existing underlying language also prevent a newly licensed pharmacist from being a manager?
Does not. I think at some point the market would control that, whether they'd want a newly licensed pharmacist in charge of their pharmacy and all the compliance and work that goes into that. This would not require that. The board has reviewed this and they're very comfortable with eliminating that requirement. So I think really it would be the market that determined whether you'd want a new pharmacist there. Okay, no questions. So section 9, it starts at the bottom of page 9. I'm sorry, section 8, it starts at the bottom of page 9 and on line 20 and goes to the next page. This is a reflection of a federal law that has preempted state laws requiring licensure for hearing aid dispensers. Hearing aid dispensers who are selling over-the-counter hearing aids, so a very specific type of hearing aid, states are no longer allowed to require a license for those folks selling just over-the-counter hearing aids. Vermont's licensure structure previously required a license for all hearing aid dispensers, regardless of the type of hearing aid they were dispensing. But because of the federal law, we now have to exempt from licensure those folks who are just selling OTC hearing aids. This section, by the way, is a list of exemptions from the licensing requirements under the audiology and hearing aid chapter. So in each chapter, you'll see on 26, there's definitions, maybe a policy, followed by prohibitions. You cannot hold yourself out as practicing as a dentist unless you're licensed as a dentist or an audiologist, followed by usually an exemption section. If you hold another license, if you're a student, and here it says, okay, if you are just selling over-the-counter hearing aids, you're exempt from licensure. So that's the context of this.
Representative Hanko.
Thank you. So in light of the law that was passed last year regarding insurance companies covering the cost of hearing aids, a lot of my constituents are really interested in getting hearing aids now. How does one consumer protect oneself from knowing, I guess, how does one know who is evaluating your hearing loss and what type of product to buy? Because I'm assuming over-the-counter hearing aids, which I have no experience with, you just walk into a store and you purchase them and there's no consultation. How do you know that the person that you're consulting with is an audiologist, or are there other specialties that can help you with the purchase of hearing aids?
Yeah, so there will still remain audiologist licensing is required. So you can check, you can tell your constituents, they can verify either from the audiologists themselves or look on OPR's system to ensure that the person they're seeing is licensed. Also for prescription level hearing aids, so you could tell your constituents to be sure you're getting the best quality product, or it's the product that works best for you. You may want to consult with your physician or an audiologist and have them direct you to what type is needed. If they're directing you to an over-the-counter hearing aid, you would probably get it from a dispenser who's not licensed. If they're directing you to a prescription hearing aid, they would need to go to a licensed hearing aid dispenser. So we'll still have licenses for hearing aid dispensers, but in folks who are selling prescription hearing aids will need to have that license. It's just if you're solely in the market of selling those over-the-counter products, that you don't need to have the license. So there's two kind of protections you could direct them toward.
Thank you. And those dispensers of prescription level hearing aids, are they listed on your website?
They would be listing as licensed hearing aid dispensers on our website as well.
Thank you.
Any other questions about the hearing aids portion?
That concludes our testimony. The only other thing is the effective date, and that would be upon passage, so. I did want to draw attention, and I'm hoping we're gonna work on it, but we've recently discovered there's a small typo in the Notary Act in terms of a reference, a statutory reference, so we may address that with Ledge Counsel later and include that language.
Yeah, I'm happy to officially to work with you if there are other technical corrections or things that we might want to include in future drafts. Absolutely. Great. Well, we will start to work on a list of folks we need to get to testify on some of these sections with you all offline, and we hope to work on this, if not next week, probably the following week. And I have flagged for a couple of the other committees that might do a drive-by where there are some of those cross-jurisdictional issues. But I think that unless the committee has any other questions, we'll take a break a little bit early and then be back at 1 o'clock for testimony on H127 around the geofencing that I know we're interested in. And then we'll return after in the second half of our afternoon before the floor. We'll be hearing a drive-by of some of the compact bills that the House Healthcare Committee's been working on, and we'll invite OPR and the Secretary of State's office back for that. I think you're going to join by Zoom, I think.
Yes, I apologize to not be here in person. I already had scheduled myself to be at Vasara for the afternoon, so I'm just going to do it from there.
But we'll do it synchronous virtual.
Awesome.
All right.